Hi everyone, Dr. Joey here. Thank you for joining me for the second video of the three-part series titled COVID-19 from A to Zyesami. I'd like to make a few quick announcements first before we begin. First, I'd like to say thank you for your continued support. The channel is really growing and it's so exciting, so please continue to like, share, subscribe, and feel free to leave me a comment as well. Also, I would like to say that the rollout didn't quite go as originally planned, and I apologize for that, but I do promise you, anytime there's an alteration in the schedule like that, it's probably because I'm getting some last-minute verification or confirmation, or trying to make sure that I got clearance, or that everything flows appropriately, because I do try my best to make sure the videos build on each other successively, and that I oftentimes will refer back to an earlier image and might not include all of that information in a later video for time's sake. But thank you so much for watching, and I did make a promise to you that this was the video I was going to start really diving into some meatier subjects and getting into some of that juicy information for you, and I don't intend to disappoint. Well, that's it for me for now. Without further ado, let's get it. COVID-19, from A to Zyesami. Part 2, COVID-19, Trials and Tribulations, the Misleading and Often Misguided Path to EUA. An overview of the COVID-19 progression. If you look here, and remember there's a pre-symptomatic phase that you go through first, followed by the symptomatic phase where the viral genome is at its highest and you're the most contagious, and then it starts to lead over into the mild to moderate illness and severe illness if you don't get those things under control early. Now, I know I said in the previous video that about day 6 to 7 is where your limit is for getting those MABs and them actually helping you out, but they actually say that you can go up to day 10 now, according to the latest research. Methods to prevent SARS-CoV-2. When we look here at the ways to prevent from getting SARS-CoV-2, especially the non-pharmacological preventive measures, hand washing, of course, consistently is the #1 way to prevent from getting any type of infection. When we talk about wearing masks, though, something that some people don't realize is wearing a mask not only prevents the infected person from spreading it through droplets that are airborne, and not only protects the non-infected person from getting infected by creating a barrier of those airborne droplets, but also it is a constant physical barrier for our hands. Many times we may touch a surface where the virus has been spread, and then without thinking about it, we go and scratch our mustache, or, we eat, or, maybe we're drinking a Coca-Cola or something and you drop the top, you grab the top, and then you screw it back onto the bottle, but in doing that, you might have just touched the area that your mouth will touch next. So wearing a mask has several different functions of preventive measures. Safe distancing is still recommended, 6 feet or more, and also natural immunity. We're really starting to see some great research now about how people who do contract the SARS-CoV-2 and then subsequently, defeat it, they have much better immunity than any of these vaccines that are out here. And I definitely would recommend that you go and take a look at the recent research coming out of Israel on that. Pharmacological preventive measures. Vaccinating. This is, of course, what has been all of the, or let's just say as we do in the South, this has been the cat's pajamas, that everyone is talking about. I don't even know what that saying means. I just know how to use it, so don't ask me. It's kind of stupid now I think about it. But anyway, okay, so vaccinating. In the U.S., we have one fully available vaccine, or fully approved vaccine, and we have 2 with EUAs only. Pfizer is the only fully approved vaccine, and then you have Moderna and the Johnson & Johnson that have EUAs. Now, the Pfizer and Moderna vaccine are both mRNA vaccines, which simply means the information that is going to go to your cells in your body to help protect itself against any infection by SARS-CoV-2, that information is going to be encoded on a messenger RNA piece and then sent directly to your cells that are going to do the work from there. The Johnson & Johnson does not use an mRNA, which that is a brand new method that we're using, but Johnson & Johnson uses a more traditional mode of delivery. They use a vector, which their particular vector is the adenovirus. For if you don't know about adenovirus, it is one of the ones that can cause common cold. Obviously, this virus is dead or attenuated. All right. The adenovirus, rhinovirus, coronavirus, all of those can cause common colds. There's many viruses that can cause what we know as the common cold, but I'm just showing you how Johnson & Johnson uses a more traditional vector rather than encoding something on an RNA strand itself as Pfizer and Moderna have done. Now, I know a lot of people have wondered, why is it that we focus so much on vaccines and vaccine approval while seemingly pushing the therapeutics to the side? Well, the reason for that is that there is a bioethical, I guess we can say quip or standardization of thought that it is better to prevent than to treat. This is where the old saying or old adage comes in that you can give a man a fish today and he will be hungry tomorrow, or you can teach a man how to fish and he will never go hungry again. Okay, when we're giving a vaccine, we are teaching the bodies how to fish. Well, you know what I mean. Not really fish, but how to protect itself from SARS-CoV-2. But if we just treat the bodies today, and even if we cure it, then they are still susceptible later to getting SARS-CoV-2 possibly. And also, when we look at it from a financial standpoint, therapeutics are expensive oftentimes, especially these mAbs that have been coming out, and they're hard to ship. They don't have very good stability or shelf lives. All right, so it's a lose-lose situation all the way around versus just sending over some injections that you can give some jabs and done with a whole population of people. So this is the ethical or bioethical conversation that's always had. So especially in times of a pandemic, the quip or the de facto thought process is that it is better to prevent than to treat. All right. And I have "and" at the bottom there, if you don't notice, because we really hope that this comes soon. This is Centenox, which has already been approved as a Class 3 medical device over in the EU as of February 16, 2021. Treating SARS-CoV-2. As a medical professional, I wanted to make sure I equipped you with some non-pharmacological means for treating this at home while you're waiting, because I'm assuming that the moment you think you may even have been in contact with someone with SARS-CoV-2, that you schedule yourself to go get tested, you or your loved ones that you're around. Now, while you're waiting, monitor your temperature. Make sure it stays below 102 degrees Fahrenheit. Take acetaminophen or paracetamol as needed. Paracetamol is not available in the United States, but it is the equivalent of acetaminophen elsewhere. Monitor your pulse ox levels to make sure that they stay above 95%. If you don't have a pulse ox machine, I definitely recommend that right after you make sure that you have a reliable thermometer at home. The pulse ox machines are going to measure your pulse as well as your SpO2, which is going to be the indirect measurement of how much your red blood cells are saturated with oxygen. Okay, it's usually seen as SpO2 on the monitors, but make sure that that stays above 95%. Monitor your respirations or those of your loved one to make sure there's no changes in the breath sounds like a inspiratory wheeze or an expiratory wheeze, or any kind of like crud or garbled sounds that you can hear while they're breathing, which could indicate pneumonia. Also make sure that there's no breathing difficulties, and by this I mean your normal day-to-day activities. If you're starting to get winded or tired more than usual, then now's the time to start going to the emergency room. Monitor to make sure that you don't get diarrhea, and if you do, please stay hydrated. Not just water, but make sure you get something with electrolytes in it. This is why things like Pedialyte and Gatorade are good in these moments, because you're going to replenish your body with electrolytes. If you don't know how that works, basically electrolytes are charged ions that are going to create an environment that is going to retain hydration and fluid within your body. And we lose those as well as losing fluids when we have diarrhea. That's the part of diarrhea that can kill you. If you want to get MABs, now is the time to contact your physician and have that conversation. Remember, this must occur before day 10. Homeostasis. The best way I can describe homeostasis in technical terms is that of all the processes that exist in a body, there's one governing concept overall to which all other orders follow as they seek to attain equilibrium or balance. Encyclopedia Britannica states that homeostasis is the self-regulating processes by which an organism maintains stability while adjusting to the conditions. Basically, in a nutshell, homeostasis is simply your body trying to balance itself. And as such, there's diffusion, which can be seen as a passive process, and then there's facilitated or active transport. Okay, we're going to delve into this much more. Don't worry. Don't get lost yet. Osmosis is the most common form of diffusion that we hear talked about. And basically, it is simply the process of water going through a permeable or semi-permeable membrane to balance out a solution. Diffusion is simply the statement of particles moving from high concentration to low concentration because it's trying to balance out. Active transport is when there are mechanisms or means that are going to physically transport a particle from one side of a membrane to the other side. Many times we're transporting something like, let's say, potassium from the outside of the cell environment to the inside of the cell environment. When we look at this image here, I want you to pay attention to the top left corner of this image. If you notice, there's a semi-permeable membrane that is there. This is, you can imagine, our membranes of our cells. This is why we talk about the extracellular versus intracellular environment. In this particular example, I want you to notice how on the left container, all right, you have on the left side of the semi-permeable membrane approximately 10% of particles that comprise that solution. Whereas the right side of it, you have about 85% of that solution is comprised of the particles. Let's imagine those particles are salt. Now, look at the container immediately adjacent to it after diffusion has occurred. Now you can see where on both sides there is a happy medium that approximately 85% of the solution on the left and the right of that semi-permeable membrane is comprised of 85% salt particles. This is balance. This is happiness. Prima facie, when you look at it, it may not seem that way, but once you understand the chemical properties and percentages, you understand it is in fact balanced. Look directly below it. This is what happens when we have the barriers breached and what is not supposed to be permeable becomes permeable. Now you have all of the proteinaceous fluid that starts to fill in the alveolar lung sac, thus causing complete collapse, ARDS, and difficult air-gas oxygen exchange. You have to think there's antibodies, macrophages, you have the viruses, you have the red blood cells, all of these particles and all of these solutes are going to then necessitate that fluids flow on each side of the permeable membranes to balance it out and try to dilute those proteins. But this is not supposed to be that permeable. This is after it's been breached and after you have apoptosis that has occurred, and this is ARDS at its later stages. When we look here, we see active transport. Specifically, we see endocytosis, which is the act that occurs when that SARS-CoV-2 latches onto the ACE2 receptor, and then the receptor will actively grab it, pull it down intracellularly, okay? The receptor, the whole thing goes inside in this form of transportation. And I said, remember to try to remind yourself there's a line here, an invisible line here. And on the left side is the lung environment, on the right side is the blood environment. And so this SARS-CoV-2 will latch on, actively transport intracellularly, replicate itself, and then transport out extracellularly, but on the blood side now of your body. The RAS system, let's talk about this. This is an important concept to know going forward, especially once we get to the Lensilumab conversation. As we see here with the RAS system, which stands for renin-angiotensin-aldosterone system, anytime you need your blood pressure to go up, your kidneys will release renin. The renin will combine with angiotensinogen from your liver to make angiotensin 1. This angiotensin 1 will then go through your lungs and be converted by angiotensin converting enzyme into angiotensin 2. That's going to have two functions. Number one is it's going to go back to the adrenal glands, which sit like little dunce hats on top of your kidneys, and cause them to release aldosterone. Aldosterone is basically what tells our bodies to conserve our salt and not let it go out of our bodies. By conserving our salts in our mineral corticoids and our just think of it as sodium. By diffusion processes that we just talked about, your body is going to reabsorb more water in the kidneys, and you're going to have less pee-pee. When you have less pee-pee, obviously your body is conserving more fluids, and that's the way that works. The other function of angiotensin 2 is it's going to directly act on your blood vessels and vasoconstrict, or make your blood vessels get tighter. And in doing that, that's going to, of course, increase the blood pressure. So now you have two different actions acting on your blood to increase its blood pressure. You have vasoconstriction directly caused from angiotensin 2, and you also are going to have higher volume inside those vessels via the water reabsorption because you have less pee-pee. RAS system take 2. I did this just so you can get a better understanding of how the kidneys are. You see the adrenal glands on top of the kidneys there. Okay, the way that I discussed in the lungs in the first video, that you're going to have vasculature that kind of lay like a sleeve over an arm. That vasculature will lay on top of your alveoli. Here you have the same thing, but you have your ureter. This is what's going to go to your bladder, and your bladder fills up with pee-pee. All right, so this is your vasculature here. The artery, remember A for away from the heart. Here's the artery that's red with oxygenated blood, bringing it to your kidney. Then after it drops off the oxygen in your kidney, it comes back as deoxygenated blood through your renal vein. Now the whole time, any of your waste that is in this blood, while it's oxygenated, is going to press throughout this kidney, and the waste that you need to get rid of, all of the toxins, are going to get filtered out and dump out right here, all right, in this ureter, the beginning stages of your ureter, and then flow on down to your bladder. Here's another just better picture, a little bit deeper into the kidney, all right? Here showing you your urine. This is all of your waste, plus whatever fluids your body needs to get rid of. And I say that because the amount of fluid your body gets rid of or retains totally depends on what your brain tells it and what the physiological principles are telling your kidneys to do, because maybe your blood pressure needs to go up or down, as we just discussed. For people who have consistently high blood pressure, depending on the root cause of it, one way to fix that is to get rid of the body fluids, and thus they get prescribed water pills, is the common term for some people, because it's going to make your body get rid of more fluids, more water. There's multiple ways to do that. One of the ways is to make your body stop reabsorbing sodium, so the sodium goes out, and by diffusion the water will follow the sodium and go out. So again, this is just a more in-depth picture of the kidney. Now, if we look deeper still, okay, we see here this calyx, which is where all of your urine will drain out and go down to the bladder. What you can't see is where it goes behind these renal pyramids here, these little fingers of the calyx. And on those fingers, the same way again as the vasculature lays like a sleeve on top of your alveolar sacs, the vascular lays like a sleeve on top of your nephron here. And here's where you have that crossover. The way that you had the bronchial tubes to cross over to vasculature, you have the ureter functions to cross over into the vasculature here. One final example here, And this just shows the distal convoluted tubule and the loops of Henle. That's all the technical names for this. The main thing I want you to see is there are distinct sections of the kidney where you're going to reabsorb different things. If you need to conserve water, you see the water is reabsorbed here. If you need to conserve sodium, you have 3 different spots here to reabsorb the sodium. And if you don't need to get rid of urea, or if you need to get rid of urea rather, you're going to get rid of that part here. Each section is specific for certain functions of what it will reabsorb or what it will discard in your urine. This is very important. This is the part that I talked about that is longer in people of African heritage. If you look at the kangaroo rat in Africa, for instance, it has tremendously long loops of Henle. That's this right here. So guess what? It has, like, let's say 100 times more the possibilities of reabsorbing its water. So that's why it pees very little, the kangaroo rat that lives over in Africa. And it can live off of just a few drops of water for a year. This is no joke, because its loops of Henle are so long, it reabsorbs all of the fluid so efficiently. And people with African ancestry, what we've seen genetically, of course, they have to live in hot, very hot climates with maybe little water. They have longer loops of Henle to help them survive longer periods of time without as much water. And that's the reason why a drug like Vital was designed for that. Pharmacological treatments now of COVID-19. Where in the COVID-19 progression cycle do specific drugs work? That's what we're going to focus on. As you see here, you have this dropping and rolling of the SARS-CoV-2 virus, as we've discussed. It's going to roll across the inner lining or inner membrane of your lungs until it latches onto a receptor and gets transported in through active transport. The first drugs we're going to discuss are the circulating mAbs, and I made that distinction for a reason. These are going to be the monoclonal antibodies that are going to work in your blood system. Let's look at this SARS-CoV virus. I want you to pay attention to how the spike proteins are designed there and the M protein there, and then look at the HE, which is right here. You don't have to know what any of this is. I just want you to pay attention to it right now. Because now, where'd it go? Where's the M protein? When we look back at the first image, I want you to look right there at the HE. This is written in blue. Now we come here. It has conserved its HE, we see, from these 2 viruses. These are both coronaviruses. But I just want you to see the spikes are different. And the HE is conserved, but the M protein is not conserved between the 2. Also, this one has an E protein. This one does not. These are important distinguishing features we're about to discuss. Circulating mAbs are going to be monoclonal antibodies that are released that are injected into your blood, okay? There's some kind of means from a health professional, and they are going to seek out the coronavirus and try to latch on to the coronavirus, thus neutralizing it. If you notice here, we have yellow antibodies that are going after this form of coronavirus. But look at this variant or strain of coronavirus. We still have these same yellow antibodies that appear to be working. But if we get to this strain, it has very little affinity that the yellow antibodies would work. The blue ones have to work for this. This is an example or a scenario that I want you to think of in that way because it's going to really help you. The way the antibodies work is they are launched at the coronavirus, and hopefully it's the correct antibodies that will work on that particular strain or variant. And these antibodies, once they latch in and seed in, then they will start to saturate the coronavirus, the actual virus itself, and they will build these antibody complexes like this. Hopefully, it will build enough around it that when the SARS-CoV-2 virus tries to drop and roll now across the receptors, you see it cannot latch on to the receptors and go intracellular into this human cell, which is the type 2 pneumocyte in particular. It cannot latch on to these ACE2 receptors now because the antibodies have saturated it. But sometimes if it doesn't have a high affinity for the particular antibody you're launching at it, then the SARS-CoV-2 virus will not get saturated enough, and you leave enough gap or space that it can latch on to the H2 receptor anyway, and then get absorbed into your type 2 pneumocyte. This is why MABs are not 100% a fix, and they cannot be the solution long term, to be honest. What I want you to notice is that the MABs heavily depend on the RBD, or the regional binding domain, which is the spike protein, for them to latch onto the coronavirus. If the coronavirus folds down like as a hinge motion, those particular spikes that those MABs are targeting, guess what? The MABs have no eyes. They are not able to see that there's a coronavirus right beside them. Okay? And so it's like a blind person who is diabetic and eating sugar desperately, and they're standing in a room full of Kit Kats and Snickers. All right? You have MABs that are in your bloodstream, and they're ready to attack and kill the coronavirus, but the coronavirus has hid its spike protein by folding it down on its hinge, and the MABs allow the coronavirus to continue proliferating unknowingly. This actually does happen. The coronavirus does have hinge properties now on its spike proteins. It's one of the variants that have come out, and this is why it's become so elusive. When we come here, remember I said that imagine there's a line here, and on the left side of the line is going to be your inner lining of your lung, and on the right side is going to be your blood vasculature. And the only way for the coronavirus to get over into your bloodstream, all right, because on the inner lining of your lung is still considered extracellular and outside your body. Only once it goes through the lung tissue and into your bloodstream is it now truly intracellular and inside your body. So the MABs circulating are going to work either by attaching and saturating this coronavirus enough that it blocks it from latching to the H2 receptor to go intracellular, or now keep in mind, to give it at this stage, you have to have known and been right on top of it. Yes, I've had exposure to coronavirus. Let me get that MAB in me right now. All right. But what typically happens is you start to have symptoms, or it's day 2 or 3 already, and you don't yet have symptoms, but the coronavirus is already replicating in your type 2 pneumocytes. And so your only hope is that the MABs catch it on the back end here and catches all these babies that's coming out and saturates the babies as they are being, going through exportation from your type 2 pneumocyte into your bloodstream. Don't worry about C. We're going to talk about that a little later. So you may wonder, what is the significance of catching it in the bloodstream? Well, remember, the SARS-CoV-2 virus infects our type 2 pneumocytes, replicates itself, comes out into the bloodstream, all right, on the back end, and then it's going to start affecting our heart muscle cells and our blood cells themselves. So we have human circulating cells, right? And this is just showing you how 2 different variants of coronavirus can then attach and infect this circulating human cell in your bloodstream because of the spike protein with its lock and key master action. So we're on the back end now. I want you to remember this. So we are after it's already been exported into the blood system. So these MABs are going to come and saturate your circulating red blood cell or coronavirus, or excuse me, not red blood cell, but your circulating coronavirus here in the blood system. All right. And it's going to saturate it. And now the coronavirus will look like this floating around. How's that going to infect now your body human cell or your antibody or your red blood cell or whatever it may be that the coronavirus is trying to affect? It can't, because it's saturated enough with the neutralizing antibody. And this is how MABs work. Exactly like this. So we see, just to reiterate, MABs can either work on the front end by saturating, all right, the SARS-CoV-2 virus enough that it cannot drop and roll and attach to the H2 receptors, thus preventing it from going into your type 2 pneumocyte in the beginning, or it can catch it on the back end and saturate it, the coronavirus, out here in the bloodstream, thus preventing it from doing further damage and attacking to your red blood cells or to your dendritic cells or any other human cell that you have. All right, and that's what B is showing here. So for the MABs to attach to these spiked proteins on the coronavirus, all right, they have to be equipped for that particular spike. when we look at this yellow spiked coronavirus, not this one, but the yellow one, this mAb is ready for it, okay? You see it fits perfectly right there. It's made for each other. It's a perfect puzzle fit piece. But what happens with the pink spikes if you have this variant of coronavirus in you? Well, here they are. That's not looking so good, is it? You're going to have another mAb, okay? That's going to be able to go against that pink spike. Now, look at these letters. You have, remember, the alpha, you have beta, you have the delta variant, you have the epsilon variant, we have the mu variant. So all of these variants of coronavirus are going to have different spike proteins with different shapes. You have to have a mAb that is going to be specific for that particular strand, is what we're getting to in this day and age. So therefore, now we're getting more complex with variants, that the variants are coming in different strains with multiple different types of spikes. So when you have one like this that has 6 different types of spikes on it, you have to send your anti-mAb 1 and anti-mAb 2, okay? And that's going to be enough to possibly neutralize it, but not completely, because look at these 3. This whole area here is unaffected by the 2 different types of mAbs you've put into the person. This is why mAbs is like a never-ending cycle that cannot be a long-term solution. These are 2 different cocktails that we have currently for the mAbs, okay? Here's the SARS-CoV-2 virus with the spike protein. We have this combination or this combination of mAb forms. One of these by themselves, forget it. It's pointless. It does not work. And now you know why. Because it has to saturate enough of those spikes that the virus cannot attach and be transported intracellularly. Already, we've seen that they're discontinuing the EUA for one of these cocktails because the new variants, they're helpless against it. Like, we've got mAbs pumped in us all day long, but they're not attaching because the new variants are being more elusive than that. They're folding down their spike proteins. They're actually intracellularly absorbing their own spikes, so to speak. Things of that nature. They are getting more and more complex. And the mAbs, we have to continuously create new mAbs that are expensive and they're horrible to ship. This just reminding you that it has to saturate it enough that there's no wide open area on the virus that can possibly attach. This is taken directly from the NIH, their clinical management therapeutics PDF that is out and currently available. These are just some notable mutations that have occurred in these different corona variants. So I want you to remember, you have the coronavirus, the original alpha, right? But then you have different variants of that coronavirus that started. But within the variants, you have different lineages and different strains that are going to form. So we're down from coronavirus family to specific viruses, to different variants of those viruses, to different strains of those viruses, and then different phenotypical expressions of those viruses. And what I mean by that is, okay, let's say you have the same 2 coronavirus variants and strains, but one of them may fold down its spike protein and the other one does not. So it's physically expressing itself differently. Sotrovimab. The thing that makes Sotrovimab interesting, and it got recent EUA approval along with Acterma, is because it actually is going to go after a conserved region of the coronavirus. What do I mean by that? Let's look here. All right. So we have beige colored spikes, we have green spikes, we have blue spikes. All right, all of this, imagine this is going to be the first lineage of the variants of SARS-CoV-2 that was released. Now, fast forward a year later, this is the current lineage of SARS-CoV-2 viruses that are circulating, okay? Let's say that when you look at this, you said, oh, immediately, I see the issue. We need mAbs that are going to go after these beige-colored spikes. Not a bad idea, okay? You just killed 1/3 of the population of the circulating coronaviruses from 2020. But now in 2021, you launch out the same mAbs to go after the beige-colored spikes. Uh-oh. how many beige-colored spikes do we see here? We see them, but we don't see any MABs attached to them. Do you know why? Because the coronavirus, they have them folded down now. You can't see those. The MABs are waiting for them. The MABs are the blind man who's desperately needing some sugar and standing in a room full of candy bars, okay? The MABs are circulating here, but they don't see the beige spikes because they're folded down. This is a new survival mechanism that the coronavirus has developed within a year. So these MABs are next going to go after the red spikes, okay? Because let's say it's a cocktail, all right? It goes for beige, number one. Number two, it goes for the red spikes. Well, the problem with that is, what if someone has these older forms of the coronavirus from 2020? Because those are still circulating around. They're not dead, you know? We just have like the new variant. It's like you still have cars from, 2010 circulating now. We just have newer cars that are out there. And so the same thing with the virus, all right? So let's say that we see now that the MABs are very effective against the red spikes here in the new lineage or the new variant class. But you have a patient now with the older variant class, and the MABs are not very effective at getting these red spikes. I wonder why. Well, I'll show you. Notice here at B7, how prominent is that spike? Not very prominent at all. So we can see why the MABs are working in a newer class, specifically for the B7 strain, because their spike is prominent enough. The MABs can see that one. You know what I mean? It can smell that candy bar. But the older variants, it doesn't know it's there. It's not prominent enough. So when we talk about a conserved region, that's going to be something that looks the exact same in the older class in 2020 as it looks in the newer class of variants and strains of 2021. That's what Sotrovimab has been able to do, is been able to sniff out a certain region that is conserved from the older and the newer class, whereas other MABs were constantly having to create them to go. It's like it's a war game. It's literally a war game of tiny invaders inside our bodies. Acterma. This is Tocilizumab, okay? This is the only MAB that is used for hospitalized patients at later progressive stages of SARS-CoV-2 or COVID-19 progression. Don't let this chart scare you. This is just showing you how one stem cell, this is why stem cells are important, by the way, it continues growing and it produces our platelets, which platelets are sticky little substances that clump together. And we need those to stop bleeding. So when you have a cut, this is what's coming to form your scab. These platelets, they're clumpy, sticky little pieces and fragments of cells that clump together, start to form a scab. And then you'll have your neutrophils here that are going to come and make sure it cleans the scab area. And that's going to be your pus at your later stages. Neutrophils comprise about 85% of our white blood cells. That's going to be the pus that you see when you pop a pimple or when a wound is starting to heal, okay? And so, anyway, this is the stem cell. You can see it grows over here into B lymphocytes also. It can differentiate into any of these cells. One stem cell. This is why they're so valuable. B lymphocytes are actually going to be the cells that produce the antibodies for your body, okay, and give you immunity. T lymphocytes are the cells that are going to destroy the foreign invading viruses, all right? Eosinophils are very specific for parasitic worms, so if you get infected, with tapeworm or you get infected with any of those other types of true worms, then eosinophil is going to take care of those. So, when we give Tocilizumab, it is an IL-6 inhibitor. IL-6 is available at these 3 junctions that I've crossed out here, and all it does is it's a chemical signal that's going to also bring about more defense mechanisms, but sometimes it can go overboard and cause uncontrollable fever and cause uncontrollable cell death, including starting to eventually destroy our own cells, and this is what starts going into cytokine storm as we know it. So Tocilizumab specifically only goes for IL-6. Now, Lensilumab, we're getting close, y'all. We're getting close to the juicy stuff, all right? We're getting close to it. Just bear with me. Lensilumab is one of the three main GM-CSF mAbs that we have that we're trying to get approved right now. And it's going to go after your granulocyte macrophage colony stimulating factor, all right? This right here, don't let the chart scare you off again. That's just this GM-CSF. It's going to help. You need all of these things at different junctions, all right, to go to the next stage, basically. And Lensilumab is going to actually attack the GM-CSF, thus shutting off all of these pathways. Once it shuts off all these pathways, you see all of these proteins that are built after it. All of these are different immune defense mechanism structures that are no longer built now, so they can't come and destroy cells, including your own. That's what they're doing. That's what Lensilumab does. Now, there's some drugs that are mAbs in this group that don't just knock off GM-CSF, but they actually knock off the receptor, which is doing the same thing. Once you kill the receptor, now the SARS-CoV-2 cannot activate GM-CSF and cause a cytokine storm for you. So whether you attack the receptor or you attack, here, again, front end or the back end, it doesn't matter. You're going to have the same result, no cytokine storm. The problem with that, all right, is remember I told you there's these little cells called neutrophils, and that's going to be 85% of your white blood cells right here? When we go attacking GM-CSF, it's going to allow these things to grow. So you can still build T lymphocytes for killing the virus. You can still build B lymphocytes for your own antibody immune defense mechanisms, but now you can't build neutrophils. And so if you get any kind of bacterial infection, you have no defense against it. Let me give you a scenario. Patient comes into the ICU, all right, they're full-blown COVID-19, ARDS, everything. You give them Lensilumab, all right, and now while they're in the hospital, they get community-acquired pneumonia. They get a strep infection or staphylococcus infection or any bacterial infection for that reason, and you don't have neutrophils, your main structure mechanism to kill bacteria. This is one of the huge safety concerns for Lensilumab, is the fact that you're going to kill any protection your body can produce against a bacterial infection. And we all know from the earlier discussions we've had already, once you get COVID-19, any type of extra infection on top of that can kill you. So any bacteria, now you're totally susceptible. Remember I told you parasitic worms? What happens if, you're in India or you're in South America and you get a parasitic worm infection of any type now, all right? You're going to die. You don't have eosinophils. Basophils have their own functions as well. You've knocked off your body to produce those. Macrophages, this is what's going to eat the actual viral infections. Well, now you can't eat and destroy the viruses because you don't have any if you give them Lensilumab. This is the dangers of that. And this is, I'm just going to drop this little cookie crumb here. This is part of the reason that I knew early on Lensilumab is not going to be approved. And for those of you who are on Yahoo and have frequent discussions with me, if you remember, I was very public when I stated that I have removed any investment from Lensilumab. This is just one of the many, many reasons why I did, but when it comes to just sticking clinically from a clinical perspective, this is one of the huge factors that was a no-go for me. Let's go to Remdesivir. Remdesivir is going to work by simply here in C at the replication center. It's going to start chucking in different nucleotides so the virus never really gets to build itself. When a virus opens up and tries to have all these little thousands of viral babies, it never gets to make the babies because Remdesivir is in here putting in false coding, and the virus is going to kill itself every time it creates a non-functioning baby. It kills it. It destroys it immediately. Remdesivir makes sure that process keeps happening, basically. Here we go again. Look on the left. We see that The SARS-CoV-2 virus comes in here, replicates itself, and goes out. That's a smooth process. On the right side, however, this cell has Remdesivir in it. SARS-CoV-2 comes here, tries to replicate itself, doesn't work. Try again, doesn't work. It inhibits the RNA replication of the SARS-CoV-2 virus. And then we come here. Can we just breathe a sigh of relief together, folks? Because what we're going to have with Zyesami, just from what we know so far, is going to protect the type 2 pneumocyte by preventing apoptosis. It's going to have antiviral properties, the same like Remdesivir, how antiviral properties, literally, it does not allow the virus to replicate itself. The same thing here. It's going to deal with capsase 3 in particular, but we're not going to get into that. That's way into the weeds. But it's going to prevent the virus from replicating itself. Zyesami is also going to make sure that you keep producing surfactant, so you're not going to go into ARDS. Now that the virus is not able to get out extracellularly and do those Batman signals, you can't have cytokine storm. What more could you want? It literally is like a missile guided from God that was left here for us. And I love that explanation that Dr. Javid gave, or that analogy, I'll say. Furthermore, as if that wasn't enough, we have recently been able to confirm that it is an IL-6 inhibitor, which is much better, and now you know why, much better than being a GM-CSF inhibitor like Lensilumab or these MABs, okay? Remember, the earlier MABs I called circulating MABs because they circulate in the bloodstream and they can work on the front or back end. These MABs right here, they work a little differently in that they're going after the GM-CSF and shutting either off the receptor or the actual GM-CSF itself. But either way, it creates all these problems because now you're just destroying your immune system and setting your patient up for disaster. Your patient is literally depending on you now as a healthcare provider to protect it from any further infection. And you don't get that with IL-6 inhibitors, okay? You're just shutting off the ability for the cytokine storm. I won't go into more than that, but just understand we're attacking the cytokine storm possibility when we just inhibit IL-6. And you still have your other defense mechanisms. And that's what Zyesami does. Okay, so that concludes the part 2 of the 3-part series titled COVID-19 from A to Zyesami. I hope that you enjoyed that video. And now we're about to go over to a little bit of the question and answer style discussion, or kind of free flow discussion. We can think of it like that, all right? There's been a lot of questions that's been kicked around. And before we went to the 3rd video, okay, that will come out next, where we really dive into Zyesami and we look at Lensilumab, not just the clinical aspects anymore, but we're going to start getting into the financials and evaluating more of the business aspects and the stocks, okay, and looking at the EUA process a little bit more. So while this video is about the clinical parts of it and also titled about the EUA, which I'm about to discuss in a little bit, the main purpose in this video was also to get everyone on that standard platform. So now when we go to the 3rd video, everyone is up to par, okay? Now, I'm about to get into some of the juicy details, all right? We've been talking about, people wanted to get more of the meat, the things that's been kicked around. You wanted to know about the juicy juice, so I brought the juicy juice. No sugar added. Okay, so without further ado, let's get ready to start talking about the juicy details.